Hello, everybody. Um, my name is Daniel Gonzalez, and this will be my case study on a patient that I saw in the cath lab. So, patient history. Who is the patient? The patient that I saw is a 64-year-old female, and she has a history of asthma, biliary cirrhosis, endometriosis of the uterus, osteoporosis, temporal arteritis, and unspecified menopausal and postmenopausal disorder. And on them, you could see the dates that they were diagnosed or the patient was diagnosed with. Um, her family history. So you can see here her family history is quite large, or there's a lot. So, hyperlipidemia from her father, heart disease from her father as well, hyperlipidemia from mother, thyroid disease from mother, and cervical cancer from mother, hyperlipidemia from sister, thyroid disease from sister, and polycystic kidney disease from brother. So you can see that there's a lot of um, diseases in the family, immediate family, and the heart disease from the father. This patient, fortunately, never smoked, never used alcohol nor drugs, but she is allergic to prednisone. So, what is active problem list with the patient right now? So, the patient is active with COPD with exacerbations, as it said in their chart. Um, she has a diastolic dysfunction with heart failure. I find this interesting and funny because in you will see later on the reason why she got the the angiogram or went to the cath lab was for the reason that there was an abnormal uh, showing on the echo. So her active problem list shows that she has diastolic dysfunction with heart failure. You would see why it's funny later on. Sorry about the typo on failure. Um, she has GERD, shortness of breath, asthma with moderate persistent or poorly controlled, allergic rhinitis, biliary cirrhosis, unspecified menopausal, like I said, or this is just also part of the history. Endometriosis of the uterus, nephrolithiasis, cholecystectomy with common bile duct with partial colon resection, osteoporosis, and you can see here that I have underlined and bolded also that her father's first MI was in his 50s, and two of her half brothers died of MI in the early 50s. So there is some cardiac background or some cardiac disease history in this patient's life. So, medication list. This medication list consists of the patient's medications that she takes at home. She's not regularly in the hospital. This is her home medication. As you can see, she has quite a bit, and all of these would pertain to her history of her past medical history. Zelastine, she gets 137 micrograms, one spray in each nostril, 2 times daily. And azelastine is an antihistamine. It's a H1 antagonist, inhibits the release of the histamine and other mediators from cells involved in the allergic response. It also inhibits the accumulation and degranulation of eosinophils at the site of the allergic inflammation. So this would help with, I guess, congestion, I believe, in the nose or any allergic response she has. Fluticasone. Fluticasone is an anti-inflammatory agent also. And you can see that it's 50 micrograms, 2 sprays in these nostril daily. So she gets a lot of sprays in the nose. Like I said, it's an anti-inflammatory agent and is extremely potent vasoconstrictor and anti-inflammatory agent. So that's what it is. Meloxicam, she gets 15 is that mg's tablet once daily, and this is an NSAID, which stands for a non-steroidal um, anti-inflammatory, and what it does is it inhibits prostaglandin synthase and leads to a decrease of the synthesis of prostaglandins, which then will result and a reduction of the inflammation. So also for reduce inflammation. The next drug she gets is Montelukast, Montelukast. How would you pronounce that? And she gets 10 microgram or 10 mg's, and she takes one tablet every evening. And this drug is an anti-asthmatic agent. Well, it's a leukotriene receptor antagonist. So that's how it is, and it's used as an alternative to anti-inflammatory medications in the management of chronic treatment of asthma. That's your history of COPD and asthma. So that's for that. Omeprazole. Omeprazole is a proton pump inhibitor, and this the way that this drug does its job is that it inhibits the I believe the hydrogen potassium ATPase in the proton pump of gastric parietal cells or parietal cells, which makes it a proton pump inhibitor. And Spiriva, we all know Spiriva, and it's Spiriva. She gets 18 micrograms daily, and this is, I believe, so Spiriva is the tiotropium bromide. So Spiriva is the brand name. The actual drug is the tiotropium bromide, and it's a cholinergic antagonist, a muscarinic receptor antagonist which acts mainly on M3 muscarinic cells or muscarinic receptors. Sorry, excuse me, located on the smooth muscle cells and submucosal glands. So it preventing smooth muscle contraction and mucus secretions. So that the Symbicort is 80 micrograms, 2 puffs BID. We give this in the hospital all the time, and this is a combination of two drugs. It's combined of budesonide and formoterol, I believe, formoterol. And the budesonide is the glucocorticosteroid, so that's the steroidal part, and the formoterol is the adrenergic beta 2 receptor antagonist. So this is more of a long-acting beta agonist. So these are more maintenance kind of drugs. Urosodiol, which is 300 mg's twice a day, and it is so urosodiol, I believe, is mainly for her GI issue or her bile issue. What it is a synthetic form of. It's funny because it's a synthetic form of urosodiol, which is the exact same name. It's what it is that it's a bile acid produced by the liver, and is excreted and stored in the gallbladder. So what urosodiol, the synthetic form, does, or the actual real form does, it dissolves or prevents the cholesterol gallstones by blocking hepatic cholesterol production and decreasing bile cholesterol. It also decreases cholesterol absorption in the intestinal tract. So that's also for that. Albuterol, you know what albuterol does. It's a short-acting beta 2 adrenergic agonist. She receives two forms of this. So she receives an inhaler form. You can see there she gets 2 puffs every 6 hours when needed, and she gets the both inhaled, but she gets the nebulized form as well, and it's 3 mLs of it. So also when needed, Q6. The next drug that she has here on her schedule drugs is the diphenhydramine, and she received this by mouth every 6 hours when needed. And what this drug does is an anti-allergic agent. So what the drug does is it competes with the free histamine for binding at the HA receptor sites, competitively antagonizes the effects of histamine on HA receptors in the GI tract, uterus, large blood vessels, and bronchial muscles. So there's multiple things. So this is her list of drugs that she takes at home. When the patient came in, the labs were all normal, and they were taken a while ago. They were taken on the 12th of May, and the patient came in on the 22nd of May for into the cath lab. Though, excuse me, the only abnormal um, value that was there was just her creatinine was low at 0.5. Here is a picture of the patient's X-ray. Um, so you can see that the full chest is nice, all exposed. The patient is upright. The spine is well aligned down the middle. Um, the trachea also seems to be nice and well aligned down straight. You can see that her diaphragms are nice and curved. Oh, excuse me. The exposure seems proper as well. You can see the vertebrae and the disc fine. Yeah, so her diaphragms are nice and curved. I believe there is one, two, three, three ribs above the clavicles, and the clavicles connect at the fourth rib posteriorly. You can see there, and her heart is hard to assess because it seems that on her right side, going down, you can see is a complete straight line down. So it's not really that nice curvature that we usually see showing the right ventricle or yeah, the right ventricle and the right atrium side, even though the right atrium is more towards posteriorly. But it's hard to assess the heart in this case. Um, Her left side of the heart is also a little bit abnormal looking. Is not doesn't have that nice concave look towards it at the left and right ventricle. It seems like it's just like a triangle shape, so it's a bit hard to assess. Um, there seems to be a very prominent vasculature. They all go back into the what would you call that, the hilum, the hilar area. So they look nice and fine. The apical part of the vessels are also prominent, which is kind of not as common to see more up in the apices of the lungs. The lungs seem fairly fine, nice. They don't seem any abnormality. There's no abnormalities actually in them. There's no um, there's no consolidations to one specific area. The angles of the costophrenic angles seem nice and sharp. There's, let's see, one, two, three, four, five, six, seven, eight, and I believe 9 ribs above the diaphragm. It gets a little bit hard to count towards after 8, but you can see on the other side there's 9. Um, and the lateral view, it's also hard to assess the heart. I can't really see the heart that well, so I don't know what much to say about the heart. So we can go to the purpose of her procedure. The purpose of the procedure, or the proposed procedure, sorry, was to get a left heart catheter coronary angiogram post PCI. And what is the reason for the procedure was because, like I said, she had an abnormal echo. And I got the echoes here. I tried to do my best to record them or have them transported here, but I had to record my phone and place it here. So here's the echo, so we can see there. Let's see if I can play it again one more time. There we go. So you can see my mouse, but you can see one of the valves there opening as the heart constricts. I'll play one more time so you guys can see. So that big tuber there, that's a vessel, I believe, right there. That's not the vessel, the valve. So you can see the valve opening there. Go to the next recording. Let's see, there we go. There we go. So here's the other one. I'm going to replay this one again for you guys. And you can see that we see two different valves there. We can see on the upper side, we can see one of the semilunar valves. It opens up nicely. But you can see down there, one of the bigger valves, when it opens up, it kind of so I can go replay that. Kind of like flutters around. Let's see. All right, not this one. I'll go back. There you go. See how it flutters around there? So I'm no expert in knowing how to interpret these, but I believe that if they said that was an abnormal echo, that it might have been that. And I will give you a quick explanation why that. I find that kind of funny that they said the reason why they're giving her an angiogram is for an abnormal echo. Here I'm going to give you the echo summary. Based on the physicians on the echo summary, everything seemed to be fairly normal. So non-dilated, non-hypertrophied left ventricle, but the apical septum, anterior wall, and apex moderately hypokinetic, and preserved wall thickness. The left ventricular ejection fraction was approximately 55%, which is low. And the rest was normal. Normal systolic right ventricle, normal size aortic root, normal structure. The trileaflet aortic valve was also normal. Normal filling pressures, normal PA systolic pressure. So the patient was sent down to the clinic to schedule coronary angiogram. Why? I do not know. If this is all normal, maybe they know something, of course, that I don't. So the plan was to have the patient go to the cardiac cath to rule out ischemic coronary artery disease. So what is the coronary artery disease? We all know what coronary artery disease is. It's caused mainly by cholesterol and plaque. Just kidding. So we all know that's not plaque, and we all know that's not just the cholesterol, or it's cholesterol mainly. So what it is, of course, we all know, how the atherosclerosis is caused. It's not something we could easily, like like uh, like Dr. Marin or Tracy said. It's not like he's going in and just scratch it off or dig it off the walls. It's it's an inflammatory response that occurs within the myocytes, or the cells of the vessel itself. So it's not really easy to remove. And how it's caused is an inflammatory response that leads to a cell cell remodeling and proliferation of the cells, and also or causes the macrophage binding with the oxidized LDLs to create this foam cell that just clumps there, causing that sclerotic vessel. That's kind of what coronary artery disease is. So the patient was going there to rule out that. The procedures that they took was the patient was going to get a left heart catheterization, and a coronary angiogram and the left ventricle gram. That's what they said there. I don't know exactly how that is interpreted, but it's a left ventricle. One thing that I could not do in this presentation was incorporate the actual video of the angiogram itself, of the them catheterizing, putting the catheter into the heart and then seeing the angiogram. But I cannot incorporate that to this, so I apologize for that. But I will give you the steps, or what the procedures they took to go to this. So the drugs that they used in the procedure was midazolam, and that's a sedative. So they used that to sedate the patient, and they used this at 8:05, which was the time of the procedure. Fentanyl also for pain, which is 8:05, which is the same time as midazolam, one after the other one. Nicardipine, they used, and this was for I think it was the antihypertensive to prevent for hypertension. And if you notice that the midazolam and fentanyl was IV, and the rest, with the exception of the Isovo, those were IVs, and these were intra-arterial. So the nicardipine was intra-arterial, was to reduce hypertensiveness of the arteries, and heparin, of course, that's for the blood. And that was also used intra-artery into the arteries, I guess, to prevent any clot forming, and while they're doing the procedure. And Isovo, I don't really know how to pronounce that. Isovu, That's all. That's just a the dye that they put into the vessels to see the contrast. So it's a um, radiopaque substance that you see it in the X-ray to see, and they use this to guide them to see where there's an occlusion in the coronary arteries. And I have the procedures here, the way they did it. So they would sedate the patient and wait until the patient is sedated, but the patient was not fully asleep. The patient was just sedated enough to not feel any discomfort or any pain during the procedures. Um, they started with the medication, the midazolam, and as soon as the patient was ready, they inserted the sheath, which is or the catheter, which is called the Terumo, which is a 6 French, and they inserted that into the right radial artery and started guiding the wire through to eventually reach the aorta into the coronary arteries. So they did that, and also they used the dye. So you can see I have here two different times at 840 and 842 because they use the dye for multiple images and also, like I said, for the left ventricle. And I apologize again for not having those images done here. What what was the full outcome of this whole procedure? Well, there was none. So they did not find anything significant in the patient's angiogram. There was no occlusion of the arteries that they were suspecting um, there to be. There was no occlusion of the arteries that could cause a coronary artery disease or could cause the echo to be um, abnormal. So there's no significance there. Plan what I would believe to reassess the patient, reassess why there was no finding in the angiogram. So redo. Oh, there's a typo there. So redo A. Oh, I meant to say redo the echo. So why not have a different physicians or a different team or another insight of this echo to reassess the patient's echo. Um, and also I wonder if they got a 12 lead. I didn't see a 12 lead there. But yeah, a 12 lead to see what they find and what's the reason, for them having this angiogram, because they said there's abnormal finding in the echo, but in the summary there was not much that was said. Mainly everything was normal. So I would want to know why they did this. So at least the plan I believe is to reassess the patient again, to see any symptoms, get 12 leads, and redo an echo to see if that abnormal finding that they found or said is still there, and then maybe again consider again for angiogram to see. But angiogram was completely clean. Um, so yeah, the patient was actually discharged, go home, and was continued to be on her regular meds. So I hope you enjoyed my presentation. Apologize again for not having the angiogram video, and hope you enjoyed it. Thank you.